Thank you very much, and thank you to the organizers, and thank you for Dr. Ahmed for making my life easier, doing a lot of the explaining of the technical details so I can just get right into the work. So what we'll talk about today is the rapid whole genome sequencing and how it improves clinical management, the cost effectiveness, but specifically within a niche population, which is the intensive care units of children's hospitals. So the Genomics Institute in San Diego started 2017, became CLIA and CAP accredited. It was founded by our CEO, Stephen Kingsmore. And what the mission and the focus of the Institute is really to provide medical management that's guided by genomic information. So it's not so much doing the test, but how can we identify the patients as early as possible, perform the test, and deliver actionable results as quickly as possible, because keep in mind during this presentation, these are children, these are babies that are sometimes less than a day old. So on an average week in the United States, there are about 74,000 live births. Of those, it's estimated that close to 3,000 are born with one of roughly 8,000 genetic diseases, and about 455 babies die before their first birthday. So you can imagine that implementing rapid precision medicine on the basis of whole genome sequencing provides the biggest opportunity to impact that child's life as well as the family. So there's a novel paradigm for management of children within the ICUs, and this is some historical information with diseases of unknown etiologies. So children in the regional intensive care units, let me just make sure this works. All right, children in the intensive care units, about 50% of those that are admitted are undiagnosed at admission. And this is what typically happens. They go through some sort of traditional medicine approach where they search for some sort of etiological diagnosis. There might be some empirical treatment during that time for the search for the diagnosis. They may improve the condition or worsen. There may be some treatment modifications, but typically right now, this cycle is about 6 to 8 weeks. Keep in mind also that these are hospital stays that also incur costs as well. About 8% of those, they might find a genetic disease. 1% might have some precision medicine available, but more than likely there's zero changes in outcome because the diagnosis happened so late. But when we implemented rapid genome sequencing and rapid precision medicine, in particular what we're calling ultra-rapid genome sequencing now, there's this similar cycle, but we're able to get a diagnosis in under 24 hours for these kids. A third of those have a genetic disease. A fourth of those receive some sort of rapid precision medicine that includes some changes in outcomes. I'll get into that in a little bit more later. So what we want to do is really decrease the time of returning a result in order to help these babies and children as quickly as possible. And we did that by implementing a rapid whole genome sequencing approach. So this is how we did it. We did this in 2018. We set out to set the world record for fastest genetic diagnosis, which we were able to implement in about 19 and a half hours. So that's from the time of sample receipt to the time we were able to return back the results to the attending physician in the hospital. It was a process that involved a lot of collaborators, Illumina, a lot of commercial vendors, and we put this whole system together. So many of you are familiar that one of the most important things with these babies that are so young, that they're often presenting with a lot of features. And it can be very difficult to manually dig into a medical record. Sometimes these medical records are very, very intense. And so the first step was how can we pull the phenotypic information automatically once the patient is admitted into the intensive care unit. So once that test is ordered, we implemented natural language processing to be able to just automatically interrogate the medical record. So that information was on hold and combined when the sequencing data was completed. So there was no manual intervention there. The next step was what we called Dr. Bot, basically the information from the natural language processing and the phenotyping, went into our database. We then ran the sample, we would then run the samples, and we had our bioinformatics pipeline set up to take that file of phenotypic information, to take the sequencing data, but then the big step here, as you can imagine, that the interpretation of the results sometimes can take a lot of time. So how do we eliminate that step? We put in some automated interpretation software. And the actual disease-causing variants were automatically identified without anybody taking a look at the results. So patients admitted, right away the test is ordered, the phenotype was extracted, sequencing, and result popped out of the automated interpretation system. This is a little bit how the automated phenotypic information or natural language processing looks. It's actually done by a program called CliniThink, and it often just interrogates the entire medical records in the EMR and highlights all the important features that are important for that particular child. And we touched about this a little bit earlier, so what's the advantage of doing rapid genome sequencing? Well, it's in some ways an all-in-one test. There are some things you can't identify, but you certainly can identify single gene variants, small insertions, deletions. Very, very good at detecting a copy number variation down to exon level, less than a KB most of the time. And when you have those patients that have recessive disorders, one might be from a copy number variant, and one might be from a single nucleotide variant. So within one test, it really eliminates the need to do multiple tests. And we've just validated our SMN and mitochondrial detection as well in one test, as well as for triplet repeat expansions. So we're really trying to enhance whole genome sequencing to really eliminate all unnecessary tests. And always keeping in mind that these are the youngest children, right? And these are babies, and we don't want to take the time to have to order multiple tests and wait for those results to come back. So here's just an example of the impact of genome sequencing for neonatal seizures. So about 1,250 genetic diseases are associated with neonatal seizures. What's interesting is that a lot of these here, particularly the ones with the genetic disease, there's a lot of treatments for them. Okay, so the early, and we heard this yesterday in one of the professor's talks, that the earlier you can get to these babies, the sooner you can treat them, because you let them go 1 week, 2 weeks, and there's a lot of long-term developmental problems that can occur. So at the time I submitted the abstract for this presentation, we had tested 55 patients were tested with neurological presentations. That accounted for about 24% of our total patient population. 53%, or 29, had received a definitive diagnosis that was associated with a known genetic disorder. 18 initially presented with seizures, and out of those, 7 out of the 8, there was a specific change in management, mostly regarding the change in medication that they received. And it also helped avoid unnecessary surgeries, further invasive diagnostic tests, and in some cases allows for palliative care decisions. Okay, so here's a case example. This is case study number 1. This patient was an 8-day-old male with bilateral ventromegaly, poor feeding, seizure-like movements, and I just took a note from the doctors, from the medical records. The doctor said, unfortunately, last night was rough with ongoing multifocal seizures that continued despite typical treatments with phenobarbital. Initial studies were negative for acquired causes such as trauma, hemorrhage, infection. The child continued to do worse. All the maximal anti-epileptics, even with those worsening seizures, there was no response to phenytoin or carbamazine, and EEGs and seizures had a typical burst suppression. So the doctor had explained to the family, I discussed this with the parents, the range of outcomes I've seen with this type of seizure, which usually entails limited life expectancy and at least moderate severe developmental disabilities. So we received the sample, and from the time we received the sample to issue the report was 39 hours. And I won't go over the entire list, but from the time that they were admitted, 72 hours from the time they were admitted to the hospital. The Patient had a autosomal recessive paradoxin-dependent epilepsy, something we heard about yesterday. These patients have mutations in the ALDH7A gene, and the phenotype fit very well with this particular patient, so we're very confident in those results. So they started on triple therapy with paradoxin, arginine supplementation, dietary lysine restrictions, EEGs background normalized, seizures stopped, all AEDs stopped within 36 hours, and they went home. What also is important is you can treat mothers if you know with subsequent pregnancies with paradoxin, if you know that their child might be affected as well. Here's study number 2, and this is an interesting case. This was a 5-year-old, so this wasn't a newborn baby. 5-year-old had a history of neonatal seizures, abnormal eye movements, severe global developmental delay, wasn't basically difficulty responding to classical anti-epileptics, came to the ER, still was having seizures even with treatment. MRI back in 2012 was normal. Now this patient had a SNP array in 2013 that came up inconclusive. Then they had a NGS panel for short-chain acetyl dehydrogenase deficiency. That was negative. Also had an epilepsy panel that was also negative in 2016. So we performed genome sequencing in about 26 hours following sample receipt. We were able to return a diagnosis of ATP, of a defect in the ATP1A3 gene. But what's really unique about this case is that this is a disorder that isn't typically associated with seizures. So keep in mind that when you have a baby that's less than a day old, even though they're coming in with seizures, that might not be the primary phenotype. Also wanted to keep in mind that there are many epilepsy panels available on the market. When we took a look in the literature, 3 had it on there. 3 companies did not have this on their panel. I also want to talk briefly about economic and clinical utility, which is very, very important. So 6 months before we implemented this rapid precision medicine approach, a baby came in with seizures. They had 42 days of empirical treatment, unrelenting seizures. They, I think, ended up doing a panel, and they received a diagnosis on day of life 43. And unfortunately, this baby had profound neurological damage. A total of 59 days in the hospital and $211,000. We implemented rapid whole genome sequencing for this baby Sebastiana. On day in life 1, we performed ultra-rapid sequencing. On day of life 3, we're able to come up with the exact same diagnosis, and they spent 17 days in the hospital, and the total cost incurred was $80,000. So not only were you able to treat this child immediately, but it was a benefit to all those involved. This is a case of a 12-month-old female, had global developmental delay, profound motor delay, and you can see here they can't really open up their fists. And as you know, as parents, they should be able to grab for the toy and reach out for it. This child had gone 12 months without a diagnosis because they weren't in a region that offered genetic testing. This diagnosis probably could have been made by exome sequencing or a variety of different panels, but they just wasn't available to them. So they came to our institute. We identified that they had a tyrosine hydroxylase deficiency, and we also heard about this yesterday. These patients can't synthesize L-DOPA to create dopamine, and so you basically are just giving them supplementing with L-DOPA. Here's 1 month after treatment. You can see now the baby is holding the hand, holding the toy, is actually following. So he reaches up and grabs for it. And here it is, here she is 3 months after treatment. So this child had gone one year, although this particular disorder tends to manifest itself within the first, second, or third month. They're not exactly born this way, but had gone a long time without a diagnosis. Okay, it's blinking for me. I think this is the last slide. So lastly, outside of just the neurodevelopmental disorders, if you take a look at the number of different affected organ systems of children that we've tested, you can see here, it's really interesting that the proportion of children tested, in particular for heart failure or cardiomyopathies, those presented with cardiomyopathies, the rate of diagnosis was 54%, and the proportion that was actionable is 71%. But what we wanted to highlight from here was the important point that these children should be getting rapid precision medicine or genomic testing completed because they have one of the highest rate of diagnosis and the highest rate of return with regards to the return of precision medicine. Just a summary, so here's Sebastiana and Maverick, the two children I just showed you the stories about. And I actually think Sebastiana started preschool last week, so proper precision medicine can be implemented in the care of critically ill children. Rapid turnaround time allows for timely medical interventions, and infants with seizures, in particular, of unknown etiology frequently benefit from this type of precision medicine. And with that, just would like to thank all the collaborators and everybody at the Genomic Institute. In particular, thank you the organizers here for allowing me to come speak. It's definitely been a pleasure and learned a lot while I was here. Thank you very much.
Thank you very much.